Now let's bring this all to a close by looking at dysfunction in the heart one more time, with the idea of drawing some important principles from this. If there is dysfunction, we said it could be diastolic or systolic dysfunction. So let's flowchart this to make it easy for you to remember. The dysfunction can be diastolic or it can be systolic dysfunction. If it's diastolic dysfunction, then this has to do with a dysfunction in filling, in the ability of the heart to fill itself. So diastolic dysfunction is really filling dysfunction, as would occur, for example, in a case of hemorrhage, severe hemorrhage. The ability of the heart to develop preload will be impaired and compromised, and this can lead to diastolic dysfunction. So basically, when we are talking about diastolic dysfunction, we are talking about filling, and this has to do with venous return and any factor that affects venous return, that decreases venous return. More important is to understand systolic dysfunction. We can say that systolic dysfunction is linked to two overall pathophysiologies or overall etiologies, what we can call pressure factors or volume factors. Pressure overload, volume overload. What do we mean by pressure overload? If the heart has to work against an increased pressure in the systemic arteries, in the aorta, in other words, anything that will increase TPR, if I have an increase in TPR, or if I have, which will give me an increase in afterload, or if I have obstruction, as would occur in aortic stenosis. An increase in afterload, TPR, as would occur in hypertension. These are pressure-related factors that can lead to systolic dysfunction. Whenever we have these pressure-related factors, any pathology that would increase diastolic TPR, any pathology that will cause obstruction in terms of aortic stenosis, increase in afterload, hypertension, these are pressure overload on the heart. The heart will have to compensate and work harder to pump this blood against that increased afterload or that increased obstruction due to an impaired valve. This can now lead to the heart developing a sort of hypertrophy. But what kind of hypertrophy? The heart developing concentric hypertrophy. Concentric hypertrophy of the heart as a response to this pressure overload. What about if we have volume overload? What do we mean by volume overload? For whatever pathology is the cause, we have an increase in end diastolic volume, as would occur, for example, in aortic insufficiency, mitral insufficiency, backflow of blood, or increased forward flow of blood. What do we mean by that? Aortic insufficiency. Because of a regurgitant valve, there is an increase in backflow into the left ventricle. Consequent to this, the left ventricle is overfilled. Mitral insufficiency, because blood is going back into the atrium, so the forward flow is increased. More blood is coming from the atrium back into the ventricles. The net result, a volume overload. When this occurs, whenever we have a volume overload, this can lead to systolic dysfunction. And how will the heart respond to this? The heart will respond to this. Of course, it has to work harder because the volume that it has to pump out is increased. Now, it's not like pressure overload where the volume is normal or constant and it has to push the same volume against an increased afterload. Here, the afterload is normal, but the volume it has to pump is increased, and this can force the heart to hypertrophy again. What kind of hypertrophy? The heart can develop what is referred to as an eccentric hypertrophy. And this is the net end result of the kinds of systolic dysfunction we can have. Either pressure overload leading to dysfunction systolically, or volume overload leading to systolic dysfunction. The final thing we want to do here to wrap this chapter up is the different kinds of pathology or myopathies that can be found in the heart. Generally speaking, we have three types of these pathology. What is called dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. Of course, you will do these in much more details in pathology, but let us now mention them to introduce you to those pathologies when you come to do cardiac pathology. Let's talk about dilated cardiomyopathy and what are some important points you need to remember for this. In dilated cardiomyopathy, the underlying etiology or pathology is the fact that the chamber of the left ventricle is dilated. So we have now a very cavernous chamber in the heart. Because of this, this forces the heart to work in a very impaired manner because of the dilated chamber. We have a dilated chamber dilation. Because of that, compensation includes increased sympathetic stimulation of the myocardium, and this will now result in systolic dysfunction of the heart. The other kind of cardiomyopathy is restrictive cardiomyopathy. Here we have decreased ventricular compliance. Decreased ventricular compliance, now this would lead to decreased diastolic filling, diastolic dysfunction. This is due to a decrease in the cavity size. Now compare this to the dilated cardiomyopathy. Here, in the dilated, the chamber size is increased. In the restrictive, the chamber size is decreased. This also would lead to increased filling pressure. Ventricular hypertrophy may or may not be present, and the systole may be maintained close to normal. The key concept here is to remember that in restrictive cardiomyopathy, the chamber is narrowed. In hypertrophic cardiomyopathy, in this condition, we also have diastolic dysfunction due to what? Muscle involvement, increased muscle stiffness, increased infiltration of the muscles of the heart. Whatever the pathology is the etiology for this. We can have an asymmetric hypertrophy of the heart where the septum very often is more commonly involved, and this can also lead to cardiac dysfunction, systolic dysfunction. So to summarize, if we're having a cardiomyopathy, it's either dilated, restrictive, or hypertrophic. Dilated, the chamber size is increased. In restrictive, the chamber size is decreased. This all has to do with filling. So now we are having a diastolic dysfunction. Of course, this can domino later on into a eventual systolic dysfunction as well. And in hypertrophic cardiomyopathy, this is basically due to the fact that the muscle is now affected. The stiffness of the muscle is now the etiology for this.